This PowerPoint will cover detecting and managing adverse drug events. Again, I'm coming out of Davis's Drug Guide, the 16th edition, pages 18 to 22. If you have a newer or older version, of course, the pages may differ. In 2017, the FDA entered 914,689 reports of adverse drug events. The reported proportion of hospital admissions due to adverse drug reaction has ranged from 6% to 12% of all admissions in older patients. Drug events or reactions are unexpected, undesired, excessive responses to a medication that results in temporary or permanent serious harm or disability, hospital admission, transfer to a higher level of care, prolonged stay, or death. There are different types of adverse drug reactions, which we will discuss in this PowerPoint. You want to make sure that you educate your patient on the medications and potential adverse drug reactions, and teach them to seek immediate health care if they start to experience these reactions. There are different types of adverse drug events. These include adverse drug reactions, dose-related reactions, drug-drug and drug-food interactions, hypersensitivity, which will be your allergic reactions, and idiosyncratic reactions. Remember, drugs can interact with other drugs, foods, vitamins, and herbal compounds. These interactions can change the way a drug works or the timing of its action. Some drugs and herbal compounds are not compatible with each other and can lead to adverse effects. You always want to make sure that when a patient is being prescribed a new medication, you want to know what other drugs they're taking, whether they're prescribed or over the counter, vitamins or herbal supplements. That's why a lot of times when you go into a doctor's appointment, they want your medication history so they can make sure they look out for possible interactions. As a nurse, if you don't know, you always want to make sure you check with the pharmacy, or you could use your drug handbook. When it comes to adverse drug reactions, they can be caused by processes within the patient's body, a drug reaction that may be unexpected and undesired. They may or may not be caused by medication errors. They may can cause an increase in hospital stays, and they may or may not be preventable. So let's talk about dose-related or toxic reactions. These are reactions that are related to renal or hepatic impairment, extremes in age such as neonates or the elderly, drug-drug or drug-food interactions, underlying illnesses, or inadequate assessment of blood levels. This pretty much relates to the patient having too much of the drug. The body may not be able to eliminate the drug fast enough, or whatever the cause may be. It's just pretty much too much of the drug. So there are some medications that do require careful monitoring or laboratory testing to prevent these dose-related or toxic reactions. Examples include things such as digoxin, aminoglycosides, anticonvulsant drugs, anticoagulants, nephrotoxic drugs, anti-infectives such as vancomycin. When it comes to these types of medications, there are some laboratory values that are important. Those include peak, trough, and half-life. We'll talk just a little bit about each of those. Um, Half-life is going to be the time needed for half of the dose to be eliminated from the body. When multiple doses are given over time, the half-life for the total dose will be calculated, or it can be calculated. Drugs that eliminate fast or rapidly usually have a short half-life, and drugs that are eliminated slowly usually have a long half-life. A lot of times, loading doses may be given for those drugs who do have a long half-life, so the patient may get a larger first dose of that particular medication. So just a little bit about peak and trough. We'll talk a little bit about these on the next slide as well. The maximum drug blood level is normally the peak. That's going to be drawn 1 to 1.5 hours after the drug has already been administered, because you're trying to get the maximum, the highest level of the medication in the blood. The trough is going to be the lowest or minimal drug blood level. So this is usually going to be drawn 30 minutes before the dose is given. This is common with vancomycin. You want to make sure that these levels are drawn at the correct time so the therapeutic levels are accurate, because if they're not accurate, this may alter or affect the dosing. So a little bit about peak and trough. These are usually used to monitor levels of the aminoglycoside family of antibiotics. These levels will be used by the pharmacist or the physician to individualize dosage levels to the maximum effectiveness. This allows drug levels to be effective but not toxic. Usually, if one daily dose is given, the trough will be measured, but if multiple doses are given, they may have both peak and trough levels drawn. Peak will be drawn after administration, and trough is going to be drawn before the next dose, usually about 30 minutes. Just a few extra tips. If the trough level is too high, toxicity can occur, so a lot of times the drug may be held or they may decrease the dose. Nephrotoxicity and autotoxicity are the primary problems of these medications. If the peak is too low, that means that there may be no or very minimal therapeutic effect of the drug. You want to make sure you check the laboratory values for peak and trough levels before administering the next dose or whatever the physician orders. You always want to make sure you report serum levels that are not within established ranges of peak and trough levels. So you always want to make sure you report those levels that are abnormal. A lot of times the pharmacist or the physician will be on top of that anyways, but as the nurse, it'll be your job to make sure you communicate that if they don't. You want to make sure you explain to the patient the purpose of the levels that are being drawn, and you want to maintain accuracy of values. Again, you want to make sure that these labs are drawn on time. So if you do have a patient that may experience dose-related or toxic reactions, medical management would include discontinuing the drug temporarily, reducing or decreasing the dose or increasing the dosing interval, providing an antidote, get careful, well-timed drug level monitoring. They may want to review all of the medications or consider dietary changes if food may have been an issue or a reason for the dose-related reaction. As a nurse, your responsibility will be to review all medications and patient history, administer your medications at the correct time. Timing is crucial with these types of medications, especially if they're being monitored by lab work. You want to make sure you're obtaining blood levels as ordered, coordinate administration with the lab technician if needed. Make sure you are assessing for signs and symptoms of toxicity. Know the signs and symptoms of whatever drug that you may be giving of toxicity. Provide education about drugs and diet, and you always want to make sure you report relevant lab values. When it comes to drug-drug interactions, pharmacokinetic and pharmacodynamic properties of one drug affect either the pharmacokinetics or pharmacodynamics of another drug, so they interact with each other. Pharmacokinetics is the process of drug movement to achieve drug action. Think about this as what the body does to the drug, versus pharmacodynamics is how the drug affects the body. Think of this as what the drug does to the body. Pharmacokinetics is the process of drug movement to achieve drug action. There are four processes included in pharmacokinetics. These include absorption, distribution, metabolism, and excretion. Again, think about what the body does to the drug when you think of pharmacokinetics. So, absorption, just a little bit about that. Remember, each route does have a different rate of absorption. There are different routes. Of course, we have oral, we have percutaneous, which will be our skin and mucous membranes. Our enteral route will be our GI tract. Our parenteral route will be our IV injections, our IM injections, our sub-Q injections. When we think about these routes, of course, our skin or the topical medications would be the slowest absorption due to the physical makeup of the skin. In our parenteral route, which would be our IV medications, our IM, our sub-Q injections will be the fastest route because these medications do bypass the intestines, the GI tract, and other organs, so it does place these medications into the bloodstream faster. A little bit about distribution. After absorption, distribution does occur within the body to tissues, organs, and whatever the specific sites of actions may be. This will depend on the physical and chemical properties of the medication and the makeup of the person taking it. Think about circulation, membrane permeability, and protein binding. After distribution, you will have metabolism. Medications are mostly metabolized in the liver. Biotransformation will occur in the liver. The liver plays the most important role due to its structure because it's able to oxidize and transform many toxic substances. The liver does degrade many harmful chemicals before they are distributed to the different tissues. So think about if the liver or any other organs that were a part of metabolism, such as the kidneys, intestines, and the lungs, were not functioning as they could. For example, if they were decreased due to aging, liver disease. Think about if these organs were not functioning as they should to their full potential. If this happened, the medications will cause accumulation because the body can't eliminate them at the rate that they normally would. So this could be a risk for toxicity for your patients. Excretion. Medications do exit the body through the kidneys, livers, bowels, lungs, and endocrine glands. The main organ for excretion would be the kidneys. A lot of gases are eliminated through the lungs. And keep in mind that other drugs do leave the body through the feces, urine, exhale air, sweat, tears, saliva, as well as breast milk. Some drugs also may leave the body in urine. Pharmacodynamics, you want to think about what the drug does to the body. Pharmacodynamics is the chemical and physiological changes that the drug causes. When you think about pharmacodynamics, you do think about a few important elements. Receptors are places on or in a cell where a drug can attach itself or bind and control cell activity. You think about the mechanism of action, which is exactly how a drug changes cell activity, as well as target tissues, which are actual cells or tissues affected by the mechanism of action. So when you think about the mechanism of action, you think about the outcome. And it could go a few different ways. You could have an intended action, which is the desired effect. This improves body function. You could have the side effects, which are the effects on cells or body tissues that were not the intended action. They are expected, but they do not occur in all patients. You could have adverse effects or adverse drug reactions that we just talked about. Or you could have allergic responses, as well as personal or idiosyncratic responses. So back to our interactions, we'll go back to drug-drug interactions. There are a few different types of drug-drug interactions. The first type will be potentiation. These are drugs with similar actions that cause an additive effect. For example, Coumadin and aspirin taken together may cause excessive bleeding. Sedatives with alcohol can cause excessive sedation. So these drugs together cause an additive effect. They give you more than what you want. Interference. One drug accelerates or slows the metabolism or excretion of another drug. For example, azithromycin taken with DIG may cause elevated blood levels of DIG, or when taken with Coumadin, there's a risk for toxicity. So interference is pretty much interfering with one another. Displacement would be two drugs competing for protein binding sites. One drug wins, and the displaced drug is active in greater quantities. The same effect is taking a higher dose of the displaced drug. So displacement means only one drug will win to bind to that site. These interactions do have a potential for serious adverse effects. So you want to know about these types of reactions. And if you don't, of course, you want to consult the pharmacist or your drug handbook. And this is where one drug decreases the effectiveness of another drug because of divergent actions. So this means that one drug makes the other drug not as effective as it would be. As a nurse, when it comes to drug-drug interactions, your responsibilities would be to check your drug guide for interactions or consult with your pharmacist, check labs for drug levels, and you want to make sure you are assessing your patients for drug effects or side effects. That's why it's important for you to know about your drugs. Also have drug-food interactions. They are very similar to drug-drug interactions, except drug-food, of course, food may interfere with the medications. Foods can alter the absorption or metabolism of medications, and certain diets may alter the bacterial flora of the intestine and may affect the metabolism of certain drugs. Some examples, mayos, which are antidepressants that are taken with tyramine-containing foods. These foods are things such as aged cheese, soy sauce, red wines, sauerkraut, anything aged, taken with mayos, which are antidepressants, may cause hypertension and intracranial bleeding. Foods that are high in vitamin K may cause an antagonistic effect with oral anticoagulants. That's why a lot of times patients who are taking Coumadin, which is warfarin, are supposed to avoid green leafy vegetables due to this effect. Dairy products cause decreased absorption of Cipro, which is an antibiotic, and can potentiate or interfere with drug reactions. So you want to be careful, and you want to also know and educate your patient about possible drug-food interactions. That way you can teach them what they may need to avoid or when there may be a better time to take medications. Also, with drug-food interactions, calcium channel blockers, which are given for high blood pressure, taken with grapefruit juice can increase effects of this drug. So if you have a patient that may be taking amlodipine, which is Norvasc, or cardizem to lower their blood pressure, they need to avoid grapefruit juice because you don't want them to have that increased effect of that drug. Also, iron taken with acidic foods can cause increased iron absorption. I know a lot of physicians or providers do tell their patients to take their iron tablet in the mornings with orange juice because it does help with the absorption, but you want to make sure your patient is aware. Herbs and supplements taken with any drugs can also potentiate or interfere with the action of the drug, so you want to always know what your patient is taking. That's why it's important to gather that history so you can educate your patient. Let's talk about hypersensitivity reactions. This could be allergic or non-allergic. We'll start with our anaphylactic, which are allergic reactions. These reactions will occur within minutes to hours after exposure and are manifested by hives, pruritus, which is itching, bronchospasms, wheezing. The patient may have vomiting, diarrhea, tachycardia, circulatory collapse. This will be a life-threatening emergency. This produces an inflammatory reaction, so this will be an emergency. So with these responses, as a nurse, your responsibilities would be to make sure you ask your patient or family about any allergies on admission. You want to make sure you document them and place the patient on an allergy bracelet so it can be accessible. You want to make sure that when anaphylaxis does occur, you stop the drug and assess the ABCs, which will be your airway, breathing, and circulation. Notify the provider, nurse practitioner, or physician assistant immediately. Make sure you stay with the patient or have someone to stay with the patient. I will go ahead and establish IV access, ensure ready access to emergency resuscitative equipment, and make sure you are monitoring your patient during the initial administration of cross hypersensitivity agents. Idiosyncratic reactions are different. These are unique to the patient. They're unrelated to the mechanism of action. These are not true allergies, but they are related to the person's genetic differences in metabolism or immune function. They usually target the skin, liver, and bone marrow. Again, they are unrelated to the dose. These reactions are unpredictable and sporadic. Reactions may include fever, blood dyscrasias, which is abnormal material in the blood. You may have some cardiovascular effects and some changes in the mental status. Your patient may become confused or altered. Like I said, these are different and you don't see them a lot, but you need to know this information. I just list some of the signs and symptoms of an adverse drug event. You may see a change in respiratory rate, heart rate, blood pressure, mental status, and it could be an increase or a decrease. You just want to be able to identify that change. You may have an occurrence of seizures, anaphylaxis, diarrhea, fever, rash, and these are just some of the signs and symptoms. I mean, there are different things that you may see, but you want to make sure that you could recognize when something is not right with your patient. As a nurse, your role in managing an adverse drug effect or event would be to stop the drug infusion, stop the medication, monitor your patient status for improvement or decline, make sure that the correct drug was given and intended. You want to make sure that the drug was given in the correct dose by the correct route. So again, that goes back to making sure before you give that medication that everything is correct. And you want to make sure that you establish the chronology of events. Make sure you know the time the drug was given or taken and know when your patient's symptoms change. Make sure you know when something went wrong. And our last slide focuses on reporting adverse events. You always want to make sure you report signs, symptoms, and your suspicions to the prescriber immediately, and you want to make sure you alert your supervisor or your charge nurse. It doesn't have to be anything wrong. It could be something that you just suspect. Something may not look right. You always want to report it. Remember, at the end of the day, the patient's safety is most important.